There we go.
Right, just admitting someone else. Let me just check. Yeah, that's recording. You're recording, brilliant. Okay, so I think we'll make a start because I'm conscious we haven't got too long. Welcome everybody. Thank you so much for attending. I'm still admitting people as I'm going, so apologies. I've just got 2 more there. I think we've got pretty much a full house, which is great news. Okay, can I just have in the chat, would it be okay if everybody just put a yes if they can see the screen and if they can hear me clearly? The screen should just say improving screening uptake, and I have an X-ray, a mammogram basically on the front screen. If you could just pop that in the chat, yes, brilliant, that's great. I don't want to. It looks like everybody can see, which is really helpful. Thank you. Okay, so there are quite a few of us on the session, so I think it would probably be better if we put questions in the chat bar. I hope that's okay with everybody. I think otherwise we are possibly going to run out of time, and what I will do is a couple of times during the session I'll stop, have a quick look at the questions, and we can go through them at that point. I hope that's okay with everybody. If you've got a burning question and you feel like you want to interrupt at that point, please put your hand up, and we can stop the session. That's absolutely fine. Okay, so I've been speaking to Nihal from Chase Meadow about this, and the session that was being requested is improving screening uptake. Obviously, everybody on this call today is a member of the Warwick and Kenilworth PCN, and some data has been shared prior to this session, which hopefully you will have had sight of. I'm going to show you some data a bit later on if you haven't, so don't worry. I'm going to move on to the next slide. Again, could I just have a confirmation from somebody that you can see the next slide? It says, what will we cover? Brilliant, great. Okay, I'm not going to spend too long on what screening is, because obviously with the people on the audience today, I don't need to go into detail on that, but I am going to cover some slides just on early diagnosis and survival, and just on the importance of screening really, and then we'll have a look at the 3 screening programs. As I said, we'll have a look at the data, so there's going to be some PCN level data but also practice level data as well, which I hope you will find useful. We're then going to move on to looking at barriers to participation. So obviously this is about screening uptake and improving screening uptake, and obviously by looking at the barriers we can start to unpick what the reasons are why people aren't attending, and then at the end of the session we'll discuss interventions to improve participation. Hope that is okay. Just omitting someone else. Okay, moving on. So early diagnosis, and this is the definition that we tend to use in our training. And in a nutshell, cancer that's diagnosed at an early stage before it has had the chance to get too big or spread is more likely to be treated successfully. If the cancer has spread, treatment becomes more difficult and generally... Oh, sorry, was somebody asking a question? I think that's okay. If the cancer has spread, treatment becomes more difficult and generally a person's chances of surviving are much lower. I think we're all pretty au fait with that definition, but I do like to kind of set the scene at the beginning of these sessions. And the next slide is just showing you how the picture's changing really. If you have a look at the graph, you can see that the trajectory is obviously on the increase, and what they're predicting is a 2% increase in incident rate between now and 2035. So this is going to mean over 500,000 cases of cancer will be diagnosed every year. You can see the grey line is all people, but males and females is blue and pink, and you can just see that males are slightly higher than females. However, survival is also improving. So at the moment we are about 50%. So 50% of cancer patients survive for 10 years or more. And what the ambition is, and when I say the ambition, I mean, the aim of CR UK, the NHS long-term plan, there's several documents that state this ambition, that by 2034, they want to see 3 in 4 people surviving for 10 years or more. And the way that we are going to do that is by diagnosing people early. So this means diagnosing people at stage 1 and stage 2 cancers. Okay, so this diagram here looks at early and late cancer diagnosis. So there's the exact figure. So at the moment, only 54% of cancers are diagnosed at an early stage. And this infographic that's produced by CRUK really describes this quite well, I think. There's variation as well, depending on the cancer type. So, for example, if you look at breast cancer, 85% of breast cancers are diagnosed at an early stage. However, if you compare it to lung cancer, only 28% are diagnosed at an early stage. And obviously, when we're talking about survival, this is really, really important, because this infographic shows that, for example, for lung cancer, if you diagnose it early, around 8 in 10 of those patients will survive for 1 year or more. However, if they're diagnosed late, less than 2 in 10. So really, really significant difference in survival. It's even greater with bowel. More than 9 in 10 people will survive bowel cancer if it's diagnosed early, but that drops right down to 4 in 10 if it's diagnosed at a later stage. So I think that's a really clear way of describing, the importance of diagnosing early. Okay, so this is where screening comes in. Again, I feel like I'm sort of telling you things that you already know, but there's some statistics to show that 63% of cancers detected through screening are at an early stage. So one of the good things about screening is that it picks up cancers way before that they've turned into anything nasty. It's also preventative as well. So, for example, with bowel screening and cervical screening, sometimes they will pick up things like polyps or abnormal cells, which if left could turn into cancer, and those can obviously be treated and removed, which means that you're preventing the cancer from growing. So there's two positives for screening. The diagram on the left of the slide breaks down your routes to diagnosis. So the large majority of patients will be diagnosed after they have visited their GP. 34% are via a 2-week wait referral, so your urgent referral, but also 25% are by routine GP referral. And you'll see that only 6% are via the national screening programmes, and obviously we would like to see that increasing. And also I just want to draw your attention to the pink box in the diagram, and this indicates the percentage that are diagnosed at an emergency. Those are people that either turn up in A&E or they are transferred to an emergency, following an appointment, and that's at 21%. And one of the issues with diagnosing at an emergency is they are very often those late stage cancers. The symptoms have got so serious that they've had to go into an emergency. So that really is a percentage that we need to reduce. Okay, so I'm not going to go through these because I'm sure you're all aware, but there's a couple of little updates which I thought you'd be interested to hear. I'm not sure if the message has reached you yet, but the National Screening Committee have now agreed to reduce the bowel screening age to 50, and we've been informed that this process will start August of this year, and I think it's going to take about 4 years to roll out the age extension scheme. And also BowelScope is being phased out. So the BowelScope was the one-off sigmoidoscopy that was offered to people who are 55. And I think with the introduction of FIT and obviously the improvements with this screening kit, the feel is that the BowelScope is no longer needed. So there's just 2 little updates for you there. Pretty much everything else on the slide I'm sure you're aware of, and I've just popped on the national targets as well. So the national target for bowel is a lot lower because uptake for bowel screening has always been notoriously low. So at the moment it's set at 60%. Breast screening is actually 80%, but they've set a minimum standard of 70%. And for cervical, it's 80%. And we're going to have a look at your data in a moment just to sort of see where everybody's sitting. Okay, let's jump onto bowel screening. I'm just going to give you a couple of headlines around bowel cancer, and then we'll move on to looking at some of the data. So it's the 4th most common cancer It accounts for 12% of all new cancers, approximately 16,000 deaths per year. So that's about 44 every day. And as I've already mentioned, when diagnosed at an early stage, almost 95% of people with bowel cancer will survive their disease for 5 years or more. There is also some really good solid evidence now to say that bowel cancer is about 50% of bowel cancers are linked to modifiable risk factors. And when I say risk factors, I mean things that are, major lifestyle factors. So, for example, healthy diet and weight, drinking less alcohol, smoking, all of those factors, they have found links with bowel cancer. So, the prevention messages really come into play there. Okay, so FIT screening. I'm pretty sure everybody knows about FIT screening now, so I won't go through this in too much detail. I think it's really important to say that obviously FIT's been around now for probably 18 months, nearly 2 years actually, and we are starting to see an increase in uptake across the board, which is really positive. So there was a prediction of 7% increase, and we are starting to see that increase, which is really, really positive. I've also just slipped this slide in here because obviously in Coventry and Warwickshire we have the symptomatic FIT process as well, which is obviously now available to GP practices and to use as an investigative test. And this slide just shows you the differences between the two tests. And I think the main point to make here is about the sensitivity of the test. The test that is used symptomatically is much more sensitive and will detect, basically make a detection with less blood presence. So that's just to keep you in the picture about that. Okay, so uptake. This is the data from 1920. So this is the latest data that we have access to, and this obviously will not really include COVID because this runs until the end of March 2020, and COVID had only just sort of kicked in then, obviously lockdown, that kind of thing. I think the next set of data will really notice a big difference. And the first thing to say is actually in your PCN, your bowel screening uptake is pretty good in comparison to other PCNs in the system, so the whole of Coventry and Warwickshire. And yeah, so the England average is 63.8%, and I think most are above that, apart from Avonside, just dipping below there. And yeah, no huge concerns, but what I always say to practices is that obviously the national targets are there as a guide, but this still tells you that 30-35% of your eligible population are still not responding to their invitation, so there is still lots more that can be done. Oh, I've got just letting someone else in. Okay, so the barriers, and I think what I will say is actually barriers for all three of the screening programs are quite similar. The only difference is that obviously bowel screening is done in the home, it's sent to you in the post, so you don't have to go anywhere. So there are slight differences, but some of these slides are a little bit repetitive, but I just wanted to make that point. So firstly, the general barriers, and as I said, this is the same for all screening programs, is just knowledge really of screening and how important it is. There are still groups of our population who are not very health literate and are not aware of the importance of screening, and also are confused about screening. So they think, well, I don't have any symptoms, I don't feel unwell, so I don't need to do my screening, which is actually the complete opposite of what they're meant to do. Fear. There's some people who fear that they'd rather not know, death is going to happen, whatever, so they don't want to know, if they've got anything growing or anything possibly developing. Motivational and practical barriers, and I think this is probably the biggest barrier for the majority of the population. So people forget, people are too busy, they've got competing demands on their time. And there'd be practical barriers. For example, they work shifts or they work very long days, they can't take time out of their day. That's probably the most common reason. However, sometimes people hold beliefs, and that's related to their culture or their gender or the level of deprivation that they're living in, and screening is just not a familiar process to them, and preventing things is just not something that they think about. And finally, the test itself. So obviously the fit test, I know it's in the home, but it's very fiddly and it's not very pleasant, and for some people that's enough of a barrier to not do the test. I should also mention practical barriers. So this can mean, so people with disabilities can struggle. So for example, somebody with manual dexterity problems, or somebody in a wheelchair, or somebody who's visually impaired, actually doing the fit kit would be quite tricky. So I think, you know, it's really important that we understand what those barriers are before we think about what we're going to do about those barriers. Okay, so what can you do to increase uptake? I've put quite a lot on these slides, but I wanted to let you know that I will share these slides with you. And obviously within the slides there are links to the resources and links to checklists and all of that kind of thing. So hopefully you will have all the information you need. If it's not on the slide, there's links where it will be as well. Okay, so the first recommendation that we make, and I think sometimes people feel that this isn't necessary. Sorry, could I ask everybody to mute? There's just a little bit of background noise. Thank you. And one of the things we ask practices to do is to ensure that all of their staff are aware of the bowel screening programme and they're familiar with the fit test. And this means every member of staff in the practice. Anybody who has contact with a patient, really, so anybody who may be taking calls, anybody who may be on reception, it's really important that they know about the bowel screening and they are able to answer questions about what the screening programme is, what the fit test is, what the rules are around screening and what age and how often, that kind of thing. We always recommend that we have a screening or a cancer lead. Obviously I've got Nihad today on the call, but also some PCNs are having conversations around having a non-clinical lead as well, and sometimes that individual can be used to do extra work around improving uptake, but I can discuss that with you after the session if that's something you would find useful. And one of the things which I think is really important, that if you are constantly doing activities to increase your uptake, it's really important to monitor your uptake as well, so you can see if you're having impact. Are you actually making a difference? Okay, so I know the next point is tricky at the moment because we haven't got patients coming into the practices, but fingers crossed this is going to change over the next few months or so. But we would also recommend raising awareness of screening. This is one of the best things that you can do to get screening on people's agenda, and this means displaying your information in your practice and using a variety of different methods. There's obviously all the leaflets and posters and all of that kind of stuff. There's also things like animations which can be used on TV screens. We've got CRUK have got a really excellent animation which has got subtitles as well, so you don't have to worry about sound interference. But also using your websites. I'm pretty sure that Nika said you use social media as well. So it's just using all of those different mechanisms to communicate. You will find that your non-responders are all very different. You may have some older people, you may have a group of males, you may have younger people, and they will all respond to different information types. The other thing which works really well is to promote bowel screening at other clinics. So, for example, your flu clinic, any health check appointments, diabetes checks, phlebotomy, any of those that are going on. It's a really good opportunity to remind patients about bowel screening, make sure they understand the importance of doing the test. Also, just finally, make the most of Bowel Cancer Awareness Month. I've got a bit of mixed feeling about this because I do agree with raising awareness and having particular weeks and days and months, because the media tend to jump onto these days to do pieces in you know, on the radio, on the telly, you know, newspaper, that kind of thing. But we would always recommend that any of your work needs to be a continual activity. So it's not just about focusing on non-responders in Bowel Cancer Awareness Month, it's about doing it throughout the entire year. And that means that one, it's not so labour intensive. You know, if you're doing it on a regular basis, you know, you're constantly contacting your non-responders, but also it kind of manages capacity as well. And sometimes we find that if GPs all have a massive focus on increasing their bowel screening, all of a sudden the colonoscopy services are struggling. So it does sometimes have a bit of a negative impact on some of the diagnostic services. That's worth bearing in mind. Okay, so endorsement. You will probably know that this is something, I think it was again about 18 months ago, GPs were asked whether they wanted to endorse bowel screening invitations, and I think it was an opt-out process, and from memory I don't think any practices opted out, so basically everybody was automatically opted in. And this means that the invitation that goes out to patients has the name of the GP practice within the invitation, so the patient feels that it's associated with their GP. There's quite a lot of evidence to show that GP endorsement will improve uptake. You know, GP is a kind of respected, trusted body, a person that, you know, that patients like to know that you're recommending. So that's something that we would really recommend. And one of the things that some practices are now doing is that they are trying to firstly to notify patients before they turn 60. So obviously using your database to pull out all those patients who are about to turn 60 and let them know that soon they will be part of the bowel screening programme, and it's really important. But also searching for your non-responders. And I'm going to mention read codes at this point. I know SNOMED's in as well at the moment. That's obviously come in recently. I will send you a list of all of the read codes after this session today. And you will know that now all of the results of screening and of FIT will get sent to you electronically, and they will be coded. So that means that you can search through your database, your EMIS database, to find all of your non-responders. It's just a really good way of pulling out the people that you need to target. And I always say to practices, it's really important that you review those lists, because it's not just a list that everybody just gets sent a message to attend. You know, there will be people on that list who it would be really insensitive to endorse screening. For example, somebody in palliative care, somebody who's already had bowel cancer, somebody who's opted out of the screening, for example. But also it's really important to look to see if there are any patients that may need adjustments. So for example, it may be that the patient has learning disabilities, or it may be that the person doesn't speak English. There may be lots of different reasons of why the person isn't attending, and if you can pinpoint why they are not attending, that means that you know, you're more likely to be able to help them. And some of the ways of contacting people, I mean, obviously there's the letter, and I know that's the standard route. Most practices do the letter. Again, this script's available, this template's available if you need them. Also telephone, and I mentioned non-clinical cancer champions, and this is where you could perhaps use somebody in this position to make phone calls and speak to your non-responders. And again, I've included a little script on there, but that's all in the resources section as well. Text messages, I know this is becoming really, really popular. So text messages to give people the heads up that their screening's due, but also text messages to remind people that they need to do their test. Opportunistically, so some practices may already be doing this, but you'll be aware that with your cervical screening, you get an automatic pop-up saying this person is overdue. You can also set your EMIS system to do this for bowel and breast. So that means that if ever you're in a consultation with a patient and that pops up, you can then have a conversation with them about the importance of attending their screening. Okay, So removing barriers, and we've talked a little bit about this already, and I've mentioned just about resources that may be helpful. I've actually had a conversation with the bowel screening hub this morning just about what kind of information they receive before they send out their invitation. So they get their information from Open Exeter, and that's who they know to contact. And I asked the question, do you know if a patient doesn't speak English, or do you know if the person has LD or low health literacy? And the answer was, but normally no. I think the level of information that they get is very low. So that will mean that the majority of people will be just sent the standard letter, which is in English, and the standard leaflet, which is in English and not easy read. So straight away, we're probably losing a section of the population who don't even understand what is being asked of them. So I think it's just worth bearing in mind that there are resources available, and if and when you are contacting your non-responders, these resources can be sent to those patients. Again, I'll provide some links. I've mentioned the animation video, and we've also got a fact sheet on how to complete the tests, but believe it or not, that's also a barrier in itself. People are very sort of nervous, they don't know how to collect the poo, they don't know how to do the test, and we've got a really good fact sheet as well. And also just bearing in mind using the different sources of information, which I think I've mentioned, just verbal, pictorial, animations. Also recommending, if people want to really talk about it in detail, they can always ring the helpline, which is available. And just finally, making reasonable adjustments. So this is really about being ready to offer support to those who ask for it. And this may mean demonstrating how to use the test. It may mean talking through screening information. I've also put on here about liaising with community health teams, just to make sure that your list of people who would need extra support is up to date. So registered LD, all of that is up to date. You have the right contact details, that kind of thing, just so you know who your patients are and what kind of extra information you can offer. Also, finally, supporting people to request replacement kits. That's a really common reason for not doing your screening kit. It's basically been chucked in the bin, or it's been put somewhere and people can't remember. And there's a phone number that you can call, and you'll get sent another kit. So just a few things on there. Just some of the resources there. There's the free phone number on the bottom left. Those you can order, or I can order for you. They're little credit card size. These are the images that you can either hand out at your practice or have them up on the wall. And just, yeah, there's a whole variety of resources. The middle one here, bowel cancer screening, that's actually an easy read guide. So there's loads and loads of images rather than lots of text. And that's really useful to use. It's useful to use for people with LD, but it's also really useful to use for people who are English is not their first language, because they can obviously understand from looking at the pictures. So that's just another tip, and there's some really helpful links for you there. Okay, just let's move on quickly to breast screening. I'm just checking time, we're doing okay. Breast cancer facts. Most common cancer, which I'm sure you're all aware, there's over 150 cases diagnosed every day. 11,400 breast cancer deaths in the UK every year. So that's less than the bowel cancer stat from the previous slide. However, 78% of women survive breast cancer, and I think that's a lot of that to do is with sort of the signs and symptoms and people more likely to present. And then finally, we talked about prevention and sort of the modifiable risk factors, and research has sort of shown around 23% of breast cancers in the UK can be preventable. Again, there's quite a lot of evidence around alcohol use, obesity, lack of exercise, healthy diet, that kind of thing. I just want to show you this slide. I think breast screening is one of the ones that can cause a little bit of debate. I've often done sessions with GPs, and that the whole debate around overdiagnosis comes up. And it's difficult because I think there's lots of varying opinions on it. But just to reassure you that the leaflet that's actually sent out with the screening invitation does cover this, and I think that's one of the things that we always say, that as long as we are making sure our patients are informed, you know, then they've got enough information to make their own decision about screening. And this infographic just shows the difference between how many deaths basically there are with and without screening. And what the research is showing is that without screening, 58 will be diagnosed with breast cancer, but with screening, 75 will be diagnosed. So it's actually not that much of an increase. When we're looking at deaths, 21 will die of breast cancer, but 16 will die with screening. And then we kind of look at the sort of overdiagnosed and have the numbers that are overdiagnosed. So in summary, with screening, 5 lives will be saved due to screening. And I think when you look at that, you can see why people sort of debate breast screening. And yeah, so I've just put that in there. Obviously, if anybody wants to ask any more questions, that's fine. Okay, so here's your uptake. I mentioned that the national target is 70%. It's actually 80, but 70% is considered a minimum standard. I'm not quite sure why they don't have a straightforward uptake target, but that's just the way they go. So England is just above the national target, which is 70.1%, and then your CCG is just below. I've just listed your practices within your PCN, and again, most are above the minimum standard. There's just one Avon-side which just falls just below. I think it's quite important to have a look at your trends as well, and you'll see that yes, you're above target, but a couple of the practices are showing a decline basically. So the trend of uptake is dropping over the years. They measure this over a 5-year period, so that's something to think about, that you know, for whatever reason, whatever barriers, you know, fewer patients are taking up their breast screening. Okay, so what are the barriers? Very, very similar to bowel. I think the difficulty with breast is that there is a bit of a fear with mammograms, that mammograms are painful. There is a bit of a rumour, and from what I've been told, they are quite uncomfortable but not painful, and that can be quite a big barrier for people. Again, there's this thing around information and knowledge, and people thinking that screening is just not relevant. You know, I haven't got any symptoms, I don't feel unwell, there's no family history, therefore what's the point? And obviously we know the importance of screening. Again, beliefs related to ethnicity, culture, deprivation, fear, again, all the same barriers are there, and also the practical barriers. So obviously with a mammogram you have to go somewhere. In your CCG area there is no static centre, as you know, it's just mobile buses that are in various points across the south of Warwickshire. And you know, for some people that's difficult. You know, they can't get there, they can't find the time, the appointment time doesn't suit them. So there's lots of practical barriers to think about as well. One of the things I wanted to mention here was we've actually had quite a lot of contact with the breast screening service. Oh, just letting somebody else in recent months, mainly because I think obviously with the introduction of your DES, your PCN, there's obviously this focus on improving screening uptake, and I think all of a sudden GP practices are having a really close look at their screening practice. And I think I know a lot of GP practices feel that they don't get a lot of information about breast screening, and I think we can talk about this after if you'd like. So we've been having quite a few conversations with the breast screening service at the moment, saying, you know, practices are frustrated, they don't know when the breast screening round is, they feel like they can't do any sort of promotion with their patients. They don't know who are attending and who are not attending, so how can they chase non-responders? And still lots of dissatisfaction with the fact that results are still paper in this day and age. And we have had quite a lot of reassurance from the breast screening service. They are struggling at the moment. I think everybody knows that with capacity and I think people being moved around. But they are actually now operating an open booking system, which means in the past patients were sent an appointment, whereas now the patient is sent a letter and then they have to either ring or go on the website or text or email to book their appointment. So that does mean that the convenience side of things is removed a little bit, because you can book an appointment that's convenient to you. And initial feedback from that is that has made a difference. So I would guess that that will probably remain when COVID's gone and things are back to normal. We are informed that GPs are sent packs of information prior to their screening round. There seems to be confusion around that. And again, it would be really useful to have that conversation with you. And are you aware of when your breast screening round is, and what do you do with your patients prior to that? And I think, again, that varies across the patch. One of the problems I think at the moment is that because there are issues with capacity, there's a huge backlog which they're trying to get through. They've estimated that they're going to be getting through that by August time. They are obviously not keen for us to focus lots of attention on improving uptake, which obviously kind of goes against, you know, the messages that we are obviously working to within our DES specification. But it's worth bearing that in mind, that obviously if we're doing lots of work around improving uptake, the actual breast screening service is struggling with capacity at the moment. So I just wanted to talk to you about that. Okay, so interventions, most of this is no different really. I think it's just to make sure that the awareness is there. So we need to be talking about screening with our female patients, making sure the leaflets, the posters, the animations are all on display, making the most of Breast Cancer Awareness Month, that's in October. Making sure that women over 70 know that they can opt in if they wish. Obviously the screening programme for breast ends at 70, but women over 70 can opt in, and often women aren't aware of that. That was paused for a little bit, sorry, with COVID, but that, I believe that started up again. Yeah, so work with your local breast screening service to promote the programme, and I'm hoping that me in this position can help kind of be that go-between between the breast screening service and you. And as I said, we're just about to release a newsletter, an update from the breast screening service, so hopefully that will answer some questions. Again, just making sure that all of your staff are aware of the programme, they understand what the process is, they understand what the criteria is, they also know when the breast screening round is, so if any patient asks them kind of opportunistically, that your staff are able to provide correct information. Again, I've mentioned the position of a non-clinical champion. You will probably be aware, as I mentioned, that the results are still on paper, which is really frustrating in this day and age. However, we have been reassured that this is on the agenda. I mean, I'm sure you're all aware of a massive focus on digital healthcare, and we've been told that at some point in the first half of this year they are going to be looking at this. So watch this space. Fingers crossed we will soon be getting electronic results. And obviously it's really important that when those results come in, they are read coded or SNOMO coded appropriately, and then that means that you can contact your non-responders or your DNAs, as they're sometimes referred to. Again, I have a list of all of the codes which I can share with you. Okay, so this the next slide is really again about reminding women and choosing which method you want to use. So obviously you've got text message, letter, phone. Again, you've got your website, you've got social media. All of those can be used to remind your patients that the breast screening round is approaching. Again, you can add pop-up alerts, and you can do this on EMIS. I can send you instructions for that as well. And I've obviously mentioned contacting your DNAs and non-responders. Endorsing the breast screening programme, and I think you know, that goes across all three screening programmes. You know, the fact that your GP is recommending something, you know, is really important to patients, obviously, but whilst continuing to respect and enable informed choice. And then just finally, removing barriers to participation. And again, that's really about having a look at your non-responders and and working out whether they need additional support. So using coding within your system. Has the patient got LD, for example, or physical disabilities, where actually going for a mammogram would really be very difficult, and you know, that's something that we really recommend doing. And again, providing the information in all the easy read versions in different languages, and that is your just some of the resources on here. There's lots of things to click which will take you to the different resources, and a lot of the resources that I've put on here are available in other languages as well. The Macmillan easy read stuff is really excellent. And finally, cervical. So 14th most common cancer, around 870 deaths a year, but 63% of women survive cervical cancer for 10 years or more. And as I'm sure you're all aware, virtually all cases of cervical cancer are caused by HPV infection. So obviously now with the HPV vaccination for boys and girls, we are seeing sort of a drop in incident rates of cervical cancer, so it's all really positive. I think one of the myths that surrounds the HPV vaccination is that sometimes young women who've had the vaccination don't think that they need to be screened. Obviously, it's really important that that message is clear. The HPV vaccination doesn't cover the patient for all types of HPV infection. It does cover you for the two of the main causes of cervical cancer, but not all. So it's really important that our patients know that. That's just a bit of a breakdown. I just thought that was really interesting to show you that actually, and I think sometimes, you know, when we're talking about the fear of screening and worrying about what will you find, this is actually quite reassuring that over 90% of women will have a normal result. 6 will have abnormal cells, but you know, only 2 of those won't have HPV infection, and 4 will be invited for colposcopy. And you know, so it's a very small percentage that actually end up having cervical cancer. So that's really important message to give out to patients. And you know, if you wanted to use that information for your promotion, you know, please feel free to. Okay, so here's your data. Again, really good. Everybody falls below target, but that is really not unusual at all. I think you're probably aware that over the last 10 years, more than 10 years, in fact, the coverage rate for cervical screening has been dropping. None of the CCGs in England are hitting that really. So there's quite a lot that can be done. And lower attendance does tend to be the younger women and the older women. The women in the middle tend to be better at attending. And again, it's the same sort of culprits really, you know, BME groups, socioeconomic, people from deprived areas, all of those patients are not as good as attending their screening appointments. Okay, so moving on, the barriers, again, I don't think there's anything different here. I think one of the main barriers is about the actual process, and probably out of the 3 screening programs, cervical is the one that's perhaps the most unpleasant or uncomfortable. And there are lots of women out there who are fearful of the actual test and the fact that it's embarrassing or it's painful. And sometimes certain groups fear things like poor hygiene, and you know, there are all sorts of myths that float around communities that you know really aren't true. Again, things like relevance of screening. People have ideas that, oh, you know, I've only ever had 2 partners, so I won't get cervical cancer. And you know, it's really important that people understand that isn't true. And obviously important that people understand the importance of attending their screening. And again, just the practical barriers. But I think actually, because the GP manages the cervical screening programme, that's probably the one that you can have the most impact on. And I'm going to talk just a little bit about overcoming barriers now. Same piece of advice, just having the lead and making sure that all of your staff are aware of the importance of cervical screening. They understand the criteria, they understand who are the non-responders. And we're talking about availability now. I know that extended access is being promoted, and it's really important that when you're chasing up non-responders or recalling your non-responders, it's really important that that's in your communication, so patients know that they can actually book an appointment before or after business or core business hours, or they can book at another practice. Some women are embarrassed to go to their regular practice. They might know the receptionist for whatever reason. So going to another practice actually really helps. So it's really important that that's mentioned in your comms. Also, I mentioned about the fear, offering pre-appointments, longer appointments, just to show women the actual process. So show them the speculum, explain the process. So it's just about offering more tailored support to women who have specific concerns or may have had a bad experience at another GP practice. You never really know what's gone on in people's past. So I think that's a really important thing to offer. I've use appropriate health promotion, because again, non-responders come in all shapes and sizes, different groups, and what works for one group won't work for the other. So it's really important that your health promotion sort of covers all of those options, so leaflets, posters, text, that kind of thing. And again, I've mentioned about using the opportunities in your routine appointments, so health visitors as well. The LD annual health check is an ideal opportunity to talk to your patients. Even if their screening isn't due, it's still a really good opportunity to kind of start getting the patient used to the screening process. Immunisations and also phlebotomy appointments, so some really good opportunities there. And then finally, following up your non-responders. Again, it's very much about using your system, using your EMIS system, using your READ and SNOMED codes to record all of the interventions, and also know who to contact who are overdue for their screening. The EMIS alert for cervical is already set up. I'm not quite sure why that one's set up and the others aren't, but I think it might have been a CCG level thing, but that alert is already on the screen. So it's really encouraging all members of staff to respond to that alert. So if there's a receptionist booking appointment and that alert pops up, it's really important that they mention it as well. And I've mentioned here just about cleansing your practice list. Sometimes you might have a patient who's left, or you might have a double entry or whatever. It's just really important to kind of regularly review your lists and continually carry out these activities. So contacting non-responders shouldn't be something you do once a year, it should be something you do once a month. And again, finally, the page of resources. So there's absolutely loads on cervical screening which you can tap into. Again, there's your easy read stuff. The NHS also do an easy read guide. It's all available in different languages. So I've popped a Polish example on there, but the link on this page takes you to all the different languages. Just some of the symptoms which are really useful to have on display in your practice. And also, let's talk about cervical cancer. That's a Joe's Trust piece of marketing which is used and used really effectively, and that's the kind of thing that you can put on your website and use on social media, that kind of thing. Okay, so come to the end. Just a few summary points really, just about the importance of screening and how important it is in the kind of fight to tackle cancer and diagnose it earlier. Informed choice, so making sure that our patients have really good balanced information so they can make their decision. I think we have to understand that there are some patients, no matter how many times you contact them and how many times you talk to them, they are not going to do their screening. And I think accepting that and exception reporting is really important. The uptake of screening can be low in certain areas, and I think understanding those barriers is really important, and obviously we've touched on that today. And this is particularly when we're talking about bowel screening. Bowel screening uptake is notoriously low. I mean, in some areas it kind of dips below 30%, which is really, really poor. And yeah, there's lots of things that can be done to increase that. We can help people understand and undertake screening by helping them to break some of the common barriers. And I always like to end on this point with never underestimating the power we have to help people and the difference we can make. I'm going to just open it up to questions now. I haven't seen any pop up. I haven't opened my screening. No, I haven't got my... yes. I knew that question was going to come up. So... yeah, so there's a mention moving towards self-testing for cervical screening. This may help with uptake. Yeah, totally agree with you. I actually attended the Cancer Research Early Diagnosis, the first virtual conference. Actually, we normally go to an event, but they did 4 virtual sessions, which were actually fascinating. And they talked about self-testing. It's most definitely on the horizon. As far as I know, there's nothing locally happening at the moment, but I will keep you posted. The people that presented on the conference I attended, they were presenting all the kind of different types of self-testing and sort of evaluating the effectiveness of each of them. So it's definitely something that's on the horizon. I can't give you any more information about that, but I totally agree. I think that would have a huge impact on uptake if we had self-testing. Has anybody got any other questions? I don't know if anybody wants to come off mic and talk about anything. I don't know whether anyone wants to make any comments on breast screening. As I said, we've been working with a couple of PCNs in Coventry recently, and there's actually been quite a lot of dissatisfaction from the GPs about breast screening and the breast screening process. And I don't know if anybody's got any experience that they want to share. As I said, we are sort of trying to open up communication lines with the breast screening service and really trying to improve the information that they're sending out. Nihai, do you want to say something?
Yeah, I think you've already touched upon it. It's just awareness of when people in the area, just so we can encourage, and actually just feedback in terms of who's had it. Really, I think we've got a bit of reminders on emails to say that they're eligible, but no idea whether they've already had it. So it becomes very difficult to opportunistically, prompt and screen, and even that would be helpful.
Yeah, okay. And what about results and that kind of thing? Has anybody got, because I mean, certain GPs that I was chatting to again from these 2 PCNs in the Coventry area was sort of saying we never see results. And then sort of sometimes the practice nurses, the practice managers will say, oh, well, we see them. And I think sometimes it's a case that they come into the practice, but then possibly aren't shared. I don't know what the process is. I know obviously, as I said, it's paper, which just seems a bit antiquated now, but it's just one of those things that we've got to work with, I think, for the time being anyway. Anybody got any more questions? Just got a silent room. Thank you. As I said, I'm going to send the slides. So everything that I've discussed today, you can go back and visit and click on the links. I would really, really recommend, so another one's come up. So any progress with PSA becoming a screening test, I can tell you the answer to that is no. There's no progress, and they've looked at, actually part of a larger screening presentation that I deliver. They talk about a couple of other cancers. So they talk about prostate, they talk about ovarian, and there's a couple of tests that have been discussed over the years. And I think the feeling is that the PSA test is just not reliable enough on its own. And obviously you guys will be aware of all those reasons. And I think the criteria that they look at to decide whether a test becomes a national screening test is a lot to do with sort of the number of lives it saves, the cost benefit analysis, that kind of thing. And I think on analysis, the PSA test didn't show that any lives were saved as making that a screening programme. They're currently looking at lung as well. You're probably aware of that. There's a couple of pilots going on across the country. There's actually one in Coventry and Rugby, which is really exciting, obviously, for our local area. And I think, depending on the results of this national pilot, there may be a lung screening test in the future, but at the moment we're just sort of piloting. It's the low dose CT scan, and obviously contacting ever smoked and current smokers. So yeah, that's happening now. That starts in April, so I'll keep you posted on that as well. But at the moment it's just the 3 main ones that are the ones that we have. I hope that answers your question. What was I going to say? Yeah, I just wanted to mention the point of the non-clinical cancer champion, and I think we've talked about this, haven't we, Neha, about the possibility of having an individual for your PCN. And I know we've had chats about this over email, and I think some of the South Warwickshire PCNs are going down the route of using a care coordinator for this post. I know Arden PCN, which is probably your neighbouring PCN, actually thinking about the geography, they have a cancer care coordinator, and that does seem to be working quite well. I know she's blitzed the cervical screening recently and has seen a huge increase, and I think just because of the level of that post, and obviously her area of expertise, she's been able to have much more detailed conversations with the patients about why they're not responding to their invitation, and that's actually been really beneficial. So that's something that I would really recommend.
I think certainly as a PCN, we've very recently appointed a new PCN manager, and I think there has been lots of suggestions about her taking on that role, but that's literally within the last few weeks. But that might be something we can arrange a kind of a meeting and have a bit more of a chat about how to incorporate that as part of a role.
Yeah, definitely. And I think a lot of what I suggested today, I'm sure we were all sat there thinking, how on earth have we got time to do all of these interventions? Because it you know, unfortunately, it is tricky depending on the type of patients that you're dealing with. But if you had a non-clinical cancer champion, that's something that they could really get their teeth into and really focus on behalf of the PCN. Obviously that individual would have access to the EMIS system and be able to pull off all of the non-responders and that kind of thing. So that's I think that's what most PCNs are using their non-clinical champions to do. Okay, thank you so much for your time, everybody. And I'm sorry it's a bit one way with the virtual. I find it really hard not getting any eye contact with anybody, but it's just the world we're in at the moment, I'm afraid. And I don't think it's going to be changing anytime soon. So I know that we've got a couple of sessions booked in. I think we discussed safety netting, didn't we, Neha? That was one of the ones that you were really keen to do, and also improving the quality of your referral as well, which kind of ties in with the safety netting. But we're in conversation, and I think it's always going to be a Wednesday lunchtime, isn't it? I think we talked about every couple of months, didn't we?
Yeah, I think we'll see how that works out. I think as you find out, some people aren't in on a Wednesday as well, but I think Wednesday seems to be the common day. But I think we've made a start, and that's brilliant.
Yeah, definitely. And as I said, this is all being recorded, so I need to fiddle around with. It's obviously been recorded somewhere. I don't quite know where it's been saved, but I'll work out, and then I will send that to you. And if you want to share it with any other GPs or anybody in the practice, actually, that's absolutely fine. And obviously, you know, we've been talking a lot about making sure all of your staff members are aware. I also do a basic awareness around screening, which would probably be more appropriate for non-clinical staff, and that's, I can make that available as well if you wanted to share that, or if you wanted me to deliver training too, that's absolutely fine.
Great, that's brilliant. Thank you so much, Kate.
No worries. Thank you so much, everybody.
Bye-bye.
Thank you. Bye.